Alrighty, our next presenter is Dr. Charles Gatt. Dr. Gatt is an orthopedic surgeon here. He's the orthopedic consultant for Rutgers and Rider Universities, as well as the chairman of the Department of Orthopaedic Surgery at Robert Wood Johnson Medical School. Dr. Gatt's going to speak on cartilage injuries.
Good morning, everybody. So Eric charged me with talking about evidence-based treatment of cartilage injuries. And the problem is there really isn't much good evidence-based medicine on the treatment of cartilage injuries, as you'll see. Most of what's been published in the literature tends to be level 4 evidence. So we just really talk about, what is the current trends and where we're going with it today. So I have no disclosures. And first question is, do our current surgical techniques restore normal articular cartilage and prevent post-traumatic arthritis of the knee? And then the other question is, do the treatment modalities that we have for cartilage injuries get athletes back to play? So first of all, I want to talk about healthy articular cartilage. And cartilage really is the holy grail. If you think about the talks that you just heard, for instance, ACL surgery, why do we do ACL reconstructions? We do it so that you have a stable knee, because an unstable knee results in meniscal tears, and meniscal tears result in damage to the articular cartilage, and that results in arthritis. Why do we treat meniscal tears? Because if you lose your meniscus, you start to damage your cartilage, and you start to develop arthritis. So in sports medicine, in addition to trying to get athletes back to play, we're also trying to get them prevent arthritis later on in life. A lot of the parents that I talk to when I treat their kids, what they really are concerned about, not as much about getting their kids back to play, is what are the consequences to my child when they turn 30 or 40 or 50 years old, because they don't want them to develop arthritis. So, cartilage is a very well-defined structure. You have the articular cartilage, which has no blood supply and has no nerve endings. So it's asensory and has no vascularity. The cells derive their nourishment through the fluid in the joint. And you can see they change. The superficial cells are flatter, the deeper cells are round. They're surrounded by proteoglycans. They come down to a tide mark where you start transition from articular cartilage to bone. And probably one of the things we're starting to understand more and more is the importance of the subchondral bone plate. In other words, cartilage sits on a specialized layer of bone between it and the cancellous bone, and it's very important probably to preserve that subchondral bone plate, because that is going to help with the mechanics of the articular cartilage. There we go. So then we look at what a hyaline cartilage is made up of. So hyaline cartilage is primarily made up of type 2 collagen, small amounts of type 9 and type 10 and type 11. It's important because it transmits loads very well. It's resistant to shear and it's resistant to compression. For most of the injuries that we see with articular cartilage, when it heals, if articular cartilage truly heals, it heals with fibrocartilage. And fibrocartilage is type 1 collagen, so it's the same collagen that makes up your ligaments and your skin and things like that. So it doesn't really have the resistance to compression that type 2 collagen has. You can see that also the fiber alignment is very random as opposed to the well-defined structure of articular cartilage. So our challenge in treating articular cartilage lesions is to, whatever we try to do going forward, the holy grail is to come up with hyaline cartilage. And you'll see a lot of times with the studies of regenerative type medicine, all we're really doing is replacing our type 2 collagen or our hyaline cartilage with fibrocartilage. So when you look at cartilage pathologies, there's two kinds. The one that we see in sports medicine that we're concerned with and want to treat are the acute chondral defects, the ones that happen as a result of impact injury or a twisting injury to the knee, and also osteochondritis dissecans. The way I describe these injuries to patients and their families is I say, imagine having a smoothly paved road with a pothole, right? And we have that pothole, and we need to fix the pothole if that's what's causing you your symptoms. As opposed to my middle-aged patients who come in and they have a more degenerative knee, I tell them, you don't have a smoothly paved road, you have a cobblestone street. And no matter what I do, I'm not going to be able to treat the cobblestone street. And there's a big difference. So our treatment modalities, again, are focused at the acute chondral injuries. We really have no way to restore, the degenerative process of articular cartilage, because it's more or less a systemic injury to the knee, right? You're starting to lose your articular cartilage, your bones becoming sclerotic, you're developing osteophytes. It's a big difference. We can't reverse arthritis. The real question is, what can we do to the acute chondral defects? Can we fill that in with good cartilage? So when you decide how you're going to treat people, one of the things is, what's the natural history? What if we don't do anything? What if we just see an injury and just leave it alone? What happens to the knee? So the question is, do chondral injuries lead to arthritis? And the truth of the matter is, there's not a lot of great evidence to say that it really does. I think everybody thinks that's the case, and we certainly think the bigger the articular cartilage lesions, the more likely you are to go on arthritis. But if you really scour the literature and try to find out, is that the case, you really can't prove it. And one of the challenges is because there are a lot of articular cartilage injuries that we never see, right? The only people that come in to see us are the ones with symptomatic chondral injuries. There's probably a ton of people walking around who have sustained a small or medium-sized chondral injury. Their knee swells. After about 6 or 8 weeks, they kind of get better. They limp around on it, and then they never go to the doctor. And you can't see it on X-ray anyway. So if they go to the emergency room, they're told, "Oh, you didn't break anything. Go see an orthopedic surgeon." And some people don't have time to go to the doctor, so they don't go. So we really don't know about those. So that comes into the natural history. You don't know what happens to the asymptomatic lesions. Certainly, there's in every aspect of orthopedics, we know that articular incongruity or an unevenness to the joint surface is going to progress to arthritis. And that's what a lot of what we're trying to do, is maintain the congruity of the articular surface. So, if you look at when we do arthroscopy, either for meniscectomy or for ACL reconstruction, this is sometimes what we'll see: a small, relatively small, full thickness chondral defect. This is probably, that probe that's in the knee is about 3 millimeters in width. And you look at that and you say, what do I do to that? It's something that I have to treat. I'm going to do an ACL reconstruction, or I'm going to do a meniscectomy, but should I be treating that lesion? The answer is, we really don't know the correct answer to that question. So I'm going to give you an example of a case now. This is kind of where you would like to see things happen if they did. This is a 17-year-old kid who was playing soccer right in Bugalo Park. He went into the St. Peter's emergency room when his knee swelled up right after the game. And luckily, one of our astute residents found this little tiny bone defect back here. And he said, well, he examined the knee. There was no ligament injury, nothing else that would be concerning. So the concern was, this is an osteochondral injury, right? So he convinced me into doing surgery literally the next day on the kid. And this is what we saw: a big chondral defect right here. And here's another arthroscopic picture of it. And here's the piece of bone and cartilage stuck underneath the lateral meniscus. So arthroscopically, we were able to shave the back of the fragment. We were able to put it back into place arthroscopically, and then pin it back into place. And we followed this kid for over 2 years. I mean, here we have normal articular cartilage with some bone on the back. This heals completely, and he ends up with a normal knee. So that's the ideal situation. In this case, we have restored hyaline cartilage. That will continue to grow or continue to function as hyaline cartilage, and that should have an outstanding outcome. As far as what we can do short of that, we have techniques for when we don't have that. Let's say that kid comes in, and now we get in and that piece is completely macerated. We can't repair it. What do we do for that? Well, microfracture is the most commonly employed technique that we have because, number one, it's been easy to use. It was popularized by Dick Steadman back in the late 1990s. And the idea being, you want to perforate the subchondral bone plate and release the marrow elements to try to get the marrow to leak into the defect. And so for smaller defects, this tends to work relatively well. The marrow fills it up. You put the patients on. They're kind of toe-touch weight-bearing for about 6 weeks after, 4 to 6 weeks after surgery, based on the size. But the problem is it heals in with a fibrocartilaginous scar. So it's not really, it's not as durable. And what we're finding is that it doesn't last as long. But here's a prospective study. This was done out of HSS looking at the outcomes of microfracture technique for articular cartilage lesions. And they did find that the patients did relatively well. They looked at the best outcomes where patients had a good cartilage repair volume. They were doing MRIs after surgery to measure the volume. Obviously, if they weren't overweight, that would help. And also the shorter preoperative duration of symptoms. So with this study, we were finding that patients can do relatively well, but it's really only for for a relatively short period of time. But even if you look at the pros, the pro data on, like Brian Cole has looked at NBA data on microfracture, there's some NFL data on microfracture, and you find that at least 75% of patients will return to their previous level of sports participation. Now, what's different in the pro athlete is that there's a motivation to get back, right? They're making millions of dollars. So you do a microfracture, and let's say they get 50 or 70% better than they were before surgery. They're relatively happy, and they're going to play. They may complain, their knee may swell, and may have to do other therapies. But as a consequence, they're still going to go back and play. The recreational athlete, at the same time, may not be as aggressive in getting back. So you do have to be careful in comparing the outcomes in high-level athletes to recreational athletes, and that's what some of the data has shown us. And then these are multiple studies that looked at the longer-term outcomes of microfracture, and all of these bring into question the durability of microfracture. In other words, patients will do well for 18 months to 2 or 3 years, but around 3 years or so, they do start to deteriorate. But again, it's a relatively quick procedure. It's done arthroscopically. They can get back, usually we'll have people start running, somewhere around 3 months after surgery, maybe 4, depending on the timing of the season, but you can get somebody back with relatively good symptoms. So it can buy them a season if you have someone who's at their senior year of their college career and they're not going on any further, or you have a high-level athlete who needs to get back and play because the team needs them. This is certainly a very viable option at this stage of the game. Now, aside from that, I'm just going to go back real quickly. Abrasion arthroplasty is one of the other techniques that people talked about. And with abrasion arthroplasty, they used to abrade the entire subchondral bone plate, thinking you would get a lot more marrow leaking into the defect. But there's more than enough studies that have shown that microfracture does better than abrasion arthroplasty, and the reason being we've maintained the integrity of the subchondral bone plate. So even though you're putting fibrocartilage on top of the subchondral bone, that works better than not having the subchondral bone plate underneath. So back in the early 1990s, autologous chondrocyte transplantation came into being, and this was started in Sweden, and this really met with a lot of fanfare. It was felt to be so groundbreaking that it was put on the front page of the Wall Street Journal. And essentially, this was a 2-stage procedure where we would have a full-thickness chondral defect, arthroscopically remove a small amount of articular cartilage from the edge of the lateral femoral condyle. So you take a couple of stripes, you'd send that cartilage to this company in Boston, Genzyme, and they would process it, break down the cartilage, harvest the chondrocytes, and then kind of get them to expand and then send them back to you in a little vial. On the second stage, which would be about 6 weeks later or so, or a couple of months later, we would actually open up the knee, we'd take a small patch of periosteum from the tibia, sew it over the defect, and this was very, very tedious, and then squirt the cultured cells into it. And then this would be treated with toe touch weight bearing for 6 weeks. So the outcomes of the surgery initially were really very good. Their early follow-up at 2 years was good. They even had some intermediate follow-up at 5 and 6 years, and started to show really good to excellent results. And when I say there wasn't a lot of good evidence-based medicine for articular cartilage, this is one of the best clinical trials that was ever run, because they had a randomized prospective study of ACI compared to microfracture, and they followed both groups of patients. So when they say that they're having these 91% good to excellent results, that's compared to microfracture results, which are down in the 75% range, so they are showing much better. The important thing about the ACI, they even took biopsies on second look arthroscopies, and the term that they always used was hyaline-like cartilage. It was never hyaline cartilage, it was hyaline-like. So on gross inspection, when you looked at the knee, it did look shiny and white, but when they took a needle biopsy, it still looked more like fibrocartilage than hyaline cartilage, but it was better than what we saw with microfracture. So, we weren't sure what was going to happen. Now, the process of harvesting the periosteal patch from the tibia, as I said, was a little bit tedious and a little bit challenging. So what's happened over the years with technology, people have come up with either using a synthetic or even a xenogenic patch. And so that's called the MACI procedure. Now it's matrix applied chondrocyte implantation. So you don't have to go down and take the periosteal patch. And again, they're seeing relatively the same results with these procedures. Seeing relatively good 95% good to excellent results in intermediate results. So it was getting patients back to sports. A lot of the patients in the Swedish study were high-level soccer athletes, and it was something that was pretty popular. But one of the worst things for treatment is, in terms of your looking at results, is long-term follow-up. And I give credit to this group again because they went back, and now we're looking at 14 to 15-year results on that same original group of ACI patients. And when they compared this at literally 15 years later, and they compared ACI to microfracture, they found that there were no major differences in the patients. 30 of the 80 patients enrolled in the original study were treatment failures, and of the ones that were not considered treatment failures, over 50% of them had radiographic signs of arthritis. So again, it comes back to the goal of articular cartilage surgery. And we say, what are we trying to do? We're trying to get symptomatic patients back to play. But if you're telling the patients, can I prevent your knee from going on to arthritis by repairing your articular cartilage? The answer probably, based on this study, is no. And this is, again, this is the best piece of evidence-based medicine that we have related to articular cartilage treatment. So it's not like I'm not against the role of ACI. I think it actually has a role. But I think you have to be honest with your patients about what you're doing. So if they're symptomatic from an articular cartilage lesion, this is probably a very good option. One of the next treatments that's also been relatively popular over the years is osteochondral allograft transplantation. So this is a case which, again, this is probably appropriate for relatively small and medium-sized defects. And what you do is you take a small piece of bone and articular cartilage. So here's a schematic, usually from the edge of the lateral or the medial femoral condyles. You taking these cores out of here, and it's usually multiple cores, so you'll see a whole stripe of them coming down. And then with a condylar defect, you patch in, you fill this in. So this is called a mosaicplasty, which goes back to my analogy of a cobblestone street. The difference is each of these pegs are covered with hyaline cartilage, but what fills in between that is usually fibrocartilage. So again, it's a treatment that is restoring some hyaline cartilage, but not all of it. But again, if we look at the midterm results of these, they're actually very good. This is Hangadi, Laszlo Hangadi, who's from Hungary, and he's actually done more of these than anybody in the world. In his long-term study, and this is about 10-year follow-up, 92% good to excellent results. And the typical findings of transplanted hyaline cartilage looks okay, but there is fibrocartilage in the defect. So what's interesting about this study and other studies that I'm going to talk about is that the patient-reported outcomes are good. So he reports 92% good to excellent results, but in the manuscripts there's no discussion on the radiographic signs of osteoarthritis. So we don't see weight-bearing films, and when they report the IKD scores, they just report the IKDC on pain and function, but not on the objective outcomes, which would be radiographic findings. So what we're seeing is we're getting good symptomatic relief with this technique, but we don't know if we're preventing arthritis, and that's my point. We're trying to get the symptomatic patients back to play, and this is another very good option. The next one is an osteochondral allograft. Now, osteochondral allografts are probably reserved for much bigger injuries. So we have the smaller lesions, which can be 1 to 2 square centimeters, the medium-sized lesions, which can be 2 to 3 square centimeters, and then the much bigger ones. And the other thing is that this is also used for failed treatment. So if you have a failed microfracture or a failed mosaicplasty, now you've probably increased the size of the damage anyway. And so the next question is, what do we do next? And osteochondral allografts have become more popular and actually have a very good role. So what you basically do is you take your injured area, and we have to find a femoral condyle that's size matched, so it has the same radius of curvature, and you can do that with radiographic and MRI studies. And let's see, yeah, and so then we'll take the plug out of the allograft condyle and put that into the knee, usually just pressure fitted into the knee, and that tends to heal in relatively well. Bill Bugby's been the one who's really presented the best data on this, and he does what's called a shell allograft. When you talked about, again, what causes the role of articular cartilage with no blood supply, there's no immune response to it. But when we put a piece of bone on the back, there is immune response to the bone. So what Bill Bugby does, he creates as small a piece of bone as he possibly can and washes it fairly thoroughly to get all the cells out, and that probably decreases the immune response. And when he looked at his results, and at his 10-year results, he has 92% good to excellent results He reports he has 8% failures, and he reports the failures as revision of the allograft, conversion to a unicompartmental, or conversion to a total knee replacement. But one of the other things that he didn't count as a failure, but he counts in his reoperations, is another operation for high tibial osteotomy. If the patients are going on to high tibial osteotomy, they're probably symptomatic. It probably means they were malaligned at the beginning of the surgery, and that's where, so I consider that another kind of failure as that particular study, although if they did it concomitantly, do the osteotomy and the allograft, that may be an important aspect of it. So if we look at the systematic reviews of the osteochondral studies, and now this is a pooled study, so it's not just Bill Bugbee, who's probably done more than any of these in the world. You see that our results are still 5-year results, 86% good to excellent results, and 10-year survival rate. So the patients, again, are doing very well. Just this is more of a randomized, another review of the literature showing that, again, patients do well. 80% of professional athletes are back at 2.5 years. So as far as, articular cartilage injuries is concerned, they are very common injuries. We really don't know the natural history. It's kind of incompletely understood. I think patient selection is very key. You have to be careful about what you see when you treat an MRI. If you have an MRI and if someone comes in, they have pain, and they have an isolated chondral defect, if there's edema around the chondral defect and they remain symptomatic for quite some time, then that's a patient that's probably going to end up moving towards surgery. But a fair amount of time, the chondral defects that we see on MRI don't have any surrounding edema. So if you give the patients enough time and kind of walk them through the recovery process, they'll probably get better with time. The challenge is that we really have no consensus on the current treatments. There's a kind of a protocol that people are following. Small lesions, either observe with benign neglect. If they remain symptomatic, microfracture. If they get a little bit bigger, we start thinking about osteochondral autografts. So for the medium size, and then for the larger ones, we either use ACI, MACI, or the osteochondral allografts. I think one of the things I need to talk about is cell-based therapy. If we look at PRP, if we look at BMAC, if we look at stem cells, the problem with those adjuncts to our treatment, or even using those as isolated treatments, is that the marketing for that has outpaced the science. In other words, you can see a billboard riding down Route 18 that says, knee pain, get stem cell injections, right? I've always told my patients, if it's a good treatment, if it's on a billboard, you have to question how good it really is. But truth of the matter is, the science behind it is actually starting to show us there may be some promise. It's just that we don't know what the final outcome is. For instance, PRP, is it leukocyte-rich PRP? Is it leukocyte-poor PRP? When we talk about stem cell therapy, if you do a bone marrow aspiration from the pelvis and you take out 20 cc's of bone marrow aspirate, there's probably 5 stem cells in that bone marrow aspirate. There's other pluripotential cells, but there aren't as many stem cells as we like to think. So when you say you're doing stem cell therapy, that's unrealistic. But if you call it, biologic or cell-based therapy, there's probably a role for that. And as our studies start to we build registries and we have people doing better research, I think we're going to have a lot of promise going forward. But we certainly know that more research is needed. So that should cover it. Any questions?
We have time for 1 or 2 questions.
Yeah.
Charlie, when do you get that microfracture or an OATS type lesion return to play?
So for microfracture, it would be. The question was, when do we let microfracture or OATS patients return to play? If I treat them and I think it's a big enough lesion, I'm going to make them touch weight bearing for anywhere from 4 to 6 weeks. Then I'll start them on walking. I try to avoid running for about 3 months, and then hopefully they're back full go around 4 months. Yeah.
With microfracture surgery, I'm thinking more on the lines of like a professional athlete.
Mm-hmm.
Is there consideration for doing it more than once?
Yes.
At 36 months, that kind of thing?
Yes.
Just restate the question.
Oh, so the question again was, with microfracture surgery, is there a thought on redoing the surgery if the patients become symptomatic again? And the answer is yes. It's certainly a viable option. I think you have to decide, again, a lot of it with professional athletes or high-level athletes comes down to timing, right? You do a microfracture, they do well for 2 years, now they start to fall off. How much time do they have left in their career? At what point in the season are they? Things like that. If there's an urgency to get them back, the fastest and most way to get them back would be to go with microfracture. If they're young enough and you say, well, you failed once and you have a long career, you have another 7 years left in your career or something like that, it may be time to say we need to pull back, take a year off, do something like an osteochondral allograft, and try to get you back, for a longer term. So there's so many other forces outside of what's best for the patient in the long run when you get to that level that it comes into play. So what is the mechanism of injury for the 17-year-old soccer player? Usually it's an impact injury. They kind of like more or less jam their knee. They plant, it's a high impact, they twist a little bit, but they don't have any ligamentous injury at all. So that tends to be the way it is.